Hi, everyone. So I'm Lindsay Sizemore, Viral Hepatitis Program Director at the Tennessee Department of Health, and I'm going to be your facilitator for these sessions. So today's agenda will include introductions and announcements, a didactic presentation on initial hepatitis C evaluation by Dr. Cody Chastain, one adult case presentation submitted by one of you, which we're really excited about, and closing remarks. So first, some in-chat introductions as well as some brief announcements. So first, if everyone could please introduce yourself in the chat, please include your name, your role, your organization, and if this is your first echo session with us. I'm going to give that just a second because sometimes I tend to talk very fast and everyone's like, please don't go on to the next task. I haven't finished this one. Okay. Great. Thank you, Jay, for specifying this is not your first session.
You're welcome.
Great. Okay, so a few quick reminders I want to highlight that you may have seen when you joined the session. So I need everyone, including the subject matter experts and the TDH team, to take 2 minutes to complete the sign-in sheet here. You can utilize the QR code on the left side of the website. I'm sorry, on the left side, or Shamia will put the website in the chat. The sign-in sheet is required for our accrediting body, and it's the only proof we have of your attendance as far as they are concerned. If you don't complete the sign-in sheet, you will not be eligible for CE. And even if you do not want CE, we still need you to complete it. So I'm going to give everyone a minute to complete the sign-in sheet. And once you're done, please give me a thumbs up. And in the meantime, Dr. Chastain, would you like to give your evaluation announcement?
Sure. I appreciate everyone being here. I'm Cody Chastain. I am one of your subject matter experts, particularly for adult hepatitis C. I'm an infectious disease physician at Vanderbilt. And one of my other roles is as the principal investigator for the Southeast AIDS Education and Training Center. And we can provide education and training for you, your team, or your clinic, regardless of where you're at throughout the Southeast, if it's pertinent to HIV or comorbid medical conditions. One way we are able to do this is to track the education programming that we help support. And so appreciate you doing the attendance tracking and doing things for the ECHO project. Chloe Tipton will actually drop into the chat box an additional registration opportunity. If you were willing to complete that for the SEATC, we'd appreciate your support in that regard as well. Thanks so much.
Thanks, Dr. Chastain. All right, seeing a few thumbs up, but not quite enough. So we're going to give it just another minute. Okay, there we go. Thanks, everybody. Next slide. So just a few quick reminders. So please turn on your video, please. We want to see your face so we feel like we're talking to someone. Please mute yourself unless speaking, and then please come off mute to ask any questions that you may have. Anastasia, has anyone joined by phone only? Nope. Great. Also, please never discuss PHI, and please treat everyone with respect. So with that, I'm going to turn it over to Dr. Chastain to present our didactic presentation for today. Dr. Chastain, please say next slide when you would like us to advance the slide for you.
Next slide. All right. Hello, everybody. I'm Cody again. Appreciate your time, engagement today. I will try to keep this brief because I think talking about cases and answering questions and making connections with us as a group is far more important than me talking with you. But we definitely want you to get some didactic material each time that you join these ECHO sessions. And so our topic for today, as you recall, for several of the last sessions, we focused on screening of whether it be adult or pediatric populations, as well as resources that you can connect people to throughout the state of Tennessee. And if you want access to some of those recordings, touch base with Heather, Mia, Lindsay, other groups, and we can actually get you connected to those prior recordings because there's some great information there. Today, what we're actually going to focus on is initial evaluation for adults as well as postpartum persons. Essentially, what's the medical evaluation or workup that is ideal / necessary / hoped for when we're considering treatment for someone with hepatitis C? Because this is something that a lot of times we may not discuss in full. A lot of times when people feel like when they're presenting at these type of conferences, it's about, well, what treatment am I going to select, or how do I navigate some of these other barriers? But actually the initial evaluation of patients is actually incredibly important to set them up for success. So with that, we can move on to the next slide. I have no financial disclosures, conflicts of interest to report pertinent to this presentation. I'm going to go to the next slide. And for me, the fundamental or existential questions that we have: why do we even need to do evaluation? Why shouldn't we just make a diagnosis of hepatitis C and just treat everybody? You get a positive antibody, you confirm with an RNA. Why don't we just jump straight to starting people on treatment? Well, I think it's also important for us to determine how much hepatitis C has impacted someone's health so we can best care for them in the future. That means assessing liver disease as well as comorbid conditions that will allow us to most effectively care for that person as well as to most effectively treat their hepatitis C. And also this comes down to this idea of harm reduction. How can we reduce harm both to the individual as well as the public health while moving them towards treatment? Treatment is great. There's no question a lot of our discussions are going to focus on selecting treatment and facilitating treatment for hepatitis C, but evaluating a person as a whole can really help us navigate their health challenges in concert with hepatitis C treatment and management. Next slide. So the first thing when evaluating some hepatitis C is simply taking a history. And the first part of that is actually trying to contextualize that diagnosis. If you're working in a primary care center, you may actually have been the person who screened a person based on universal recommendations. Or if you're a pediatrician and you screened an infant based on appropriate guidelines, you may have been the one to make the diagnosis. But you also might be working in the health department, especially clinic or elsewhere, where that person is actually getting connected with you for care for hepatitis C. In that context, asking about the timing and when, where, and how that diagnosis was made, asking about whether they ever had prior symptoms of acute hepatitis, like yellowing of the eyes, yellowing of the skin, severe nausea, vomiting, or abdominal discomfort, can be helpful in identifying a timeline of when they may have been infected. Also, determining whether that person's ever been evaluated and or treated. They may have had ultrasounds, they may have had liver biopsies, they may have actually started on either older hepatitis C therapies or newer hepatitis C therapies. All that can really be important information to actually get a person on the best possible treatment. Next slide. There are multiple risk factors. We have been moving the field away from targeting risk factor-based screening. We've been talking more and more about universal screening for everyone age 18 to 79 at least one time in their lifetime. Screening for infants who are born to hepatitis C positive persons. Those things are all real, but we also recognize in the real world, there's also going to be opportunities to do risk factor-based screening. Just because someone had a hepatitis C screening at some point in the past doesn't mean that they wouldn't benefit from hepatitis C screening in the future. So asking about risk factors can be helpful in identifying who might need repeat screening, but also asking about risk factors can help us identify people who may be at risk for reinfection. Because if we treat hepatitis C and we don't connect people with any counseling, information, and or harm reduction activities, then people can be at risk for reinfection. And so identifying how somebody was infected can often directly translate into how we counsel them moving forward. So I will still ask patients about whether they've had a blood product administration in the past, whether they've had prior surgeries, particularly in the distant past, whether they've had tattoos or piercings, particularly in unregulated settings, if they've injected drugs or inhaled drugs through their nose even once, if they've had unprotected sex, whether it be with the same or opposite partner, as well as part of the history, contextualizing their age, because we recognize that certain age cohorts are at higher risk for having had exposure either through healthcare or through other activities. You might say, well, Cody, why are you going to ask about blood products? Because blood is much safer now than it was prior to 1992. Well, that doesn't mean that your patient or client doesn't assume that their infection was from one thing or another. I have many patients who assume that they were infected through unprotected sex, but yet they've had multiple tattoos placed in unregulated settings. And in that context, actually helping counsel the patient collect all the risk factors can help build a bridge to a shared understanding of what the most likely exposure was and how to protect moving into the future. Next slide. Symptoms of hepatitis C infection are things that I screen for. Chronic hepatitis C infection, once you get beyond the acute phase, are nebulous. Many patients are asymptomatic, but fatigue, joint pains, chronic abdominal pain, insomnia, as well as many other non-specific symptoms can occur with people with chronic hepatitis C. And so in that context, I think it's also important for us to assess our patients, not specifically to tell them, oh, well, if we treat your hepatitis C, all these things will be better, but also to get a shared understanding of what the patient thinks may be being driven by their hepatitis C. I've had some patients who feel that they have no symptoms for the hepatitis C, but yet once they're treated, they feel dramatically improved. I've had other patients who feel that every symptom that they have is attributable to hepatitis C, and actually coming to a shared understanding of what hepatitis C may or may not contribute to is important to make sure that treatment is being pursued for the right reasons and that people can judge success appropriately. Next slide. There are symptoms of advanced liver disease. If a patient develops advanced fibrosis of their liver and cirrhosis, they may be at higher risk for upper gastrointestinal bleeding, losing of fluid into their abdominal or peritoneal space called ascites, confusion due to toxic buildup that is not filtered by liver called hepatic encephalopathy, or a collection of these things that can be defined clinically as liver failure. If a patient has had these in the past, that's also critically important information that we can utilize to adjunctively evaluate the likelihood of them having advanced liver disease and determine the most appropriate treatments. Next slide. Other medical history is also pertinent. Other medical conditions, family history, particularly of liver disease, alcohol use, non-prescription drugs, as well as prescription medication, over-the-counter medication, herb, and supplement reviews are all critical. Because ultimately, some of this information is absolutely pertinent for us choosing the best and most optimal regimen for someone's hepatitis C. It's great we've got a subject matter expert like Dr. Allen on calls with us, because this is actually a key component of selecting the best possible regimen that is most convenient, safe, and feasible for someone. And without an adequate prescription over-the-counter herb and supplement history, we can't always choose the best and safest option for our patients. Next slide. Additional social history that I routinely collect, I try to really emphasize to the residents, interns, medical students, as well as other staff that work with me, is that taking a social history is far more than do you smoke, do you drink, do you use any drugs. A social history to be comprehensive to best care for people with hepatitis C really needs to contextualize where do they live, what type of support services do they have, where do they work. Is that going to be a barrier for them being able to engage in care or other treatments? What type of transportation do they have? What type of support system, both from a personal standpoint, but also from a financial standpoint, to be able to access treatment and other resources? All these are critically important for individuals to be able to successfully engage in care. Next slide. The physical exam for people with hepatitis C often is completely normal. There's often no evidence of disease. However, two things that we can consistently look for are assessment for signs of chronic liver disease, which might be redness of the palms, palmar erythema, spider nevi, which are basically outgrowths of small vascular lesions under the skin, gynecomastia or breast enlargement, jaundice, yellowing of the skin, as well as eyes, ascites, I already mentioned, encephalopathy, already mentioned. Also, we recognize that injection drug use can be one of the leading risks of new hepatitis C infections. And so part of a physical exam, I would typically look for any stigmata of or evidence of recent or prior injection drug use. Recognize that many clients or patients may not feel comfortable disclosing that history because they may have been judged in different clinical settings in the past. This is not for me to identify someone to screen them out from treatment. It's rather to optimize the care that I can provide to that individual in a holistic way. Next slide. A lot of this stuff, a lot of people say, well, we do all that, but I will actually take the history and the physical can add so much. What we often immediately pivot to are thinking about, well, what labs do I need to assess? And I'll tell you that the lab assessment is actually pretty darn straightforward. At this point, within the past 6 months, a patient should have had a complete blood count, an estimation of their kidney function, typically with a creatinine level that can be calculated to an estimated glomerular filtration rate, a hepatic function panel, which can measure the degree of inflammation in the liver. An international normalized ratio, or INR, is not required for all patients. It's something that you can consider if you suspect advanced liver disease. Anytime prior to treatment, A quantitative hepatitis C RNA should be obtained to confirm active infection. I'll note that a hepatitis C virus genotype is not required, but it can be a tool that might help you identify a specific regimen. And for some patients, if they have a specific payer, it might be required as part of prior authorizations or other aspects. But I want to highlight that it is not a requirement as far as treatment, because we do have pan-genotypic regimens that can be used. Screening for HIV and screening for active hepatitis B infection are critical components to make sure that we're treating patients effectively, especially since shared risk factors, it can spread hepatitis C as well as hepatitis B and HIV. Additional hepatitis B serology testing may also help you determine vaccination status and or eligibility, but they aren't required. The surface antigen is the key test to determine whether there's an active infection or not. And then before starting, pregnancy testing for people who can become pregnant is a critical piece to basically counsel an individual about the safety of that hepatitis C treatment and also to negotiate and navigate that course. I can move to the next slide. Staging liver fibrosis or their MEDAVIR status is important for several different reasons. I apologize, I didn't mean to put animations in here, but there are some important elements of staging. It can help us identify the patients in greatest need of therapy, identify the patients who need cirrhosis-specific care, and it can help us triage resources if we're limited and we need to focus on the patients at the highest risk of medical issues. There are different types of staging: liver biopsy, biomarkers, and elastography. But I think the main thing I want you to take away is that staging is still important, but there's different ways for us to do this. Next slide. Historically, we use the MEDAVIR scoring system, which is based on a pathologic or a pathology-based system, which basically says a 0 is no scar tissue or no fibrosis, different levels of scar tissue all the way up to severe scar tissue, which we rate as a level 4, also known as cirrhosis. You may hear patients saying that I've got stage 4 cirrhosis or I've got stage 4 scar tissue. That can be very scary for patients to hear that level 4 or stage 4, because a lot of people take that interpretation from metastatic cancer, which is often that stage 4 interpretation. But a level 4 on the MEDAVIR scoring system really is just the equivalent of severe scar tissue. Next slide, please. Liver biopsy is historically the gold standard, and it can be used for other liver diseases, but it has been years since I've requested one specifically to assess fibrosis in the context of hepatitis C. This is a gold standard, but the problem is it can still be impacted by quality of specimen, like the length of the biopsy, and it can be costly, it can be harmful, and you require access to a specific procedure list. So often we do not rely on liver biopsies, and except in very complicated cases that have overlap medical conditions. Next slide. There are indirect markers of liver fibrosis. The AST to platelet ratio index and the FIB4 index are two different scores that actually perform relatively well across the population, just using things like AST and platelets or age, AST, platelets, and ALT as mechanisms to rule in or rule out severe fibrosis or cirrhosis. If you have numbers that score very high, there's actually high specificities or positive predictive values of severe scar tissue being present. If the numbers are very low, also the likelihood that cirrhosis is present is quite low. That being said, these are not perfect tests, and they can be impacted by a variety of other medical conditions, as well as in the FIB4 index's context, age. There is a proprietary test called FibroSure that has multiple known inputs in a proprietary equation. It's recognized by many payers, but some specialists really don't feel that it performs at any better level than the APRI or FIB4 index. If we move to the next slide, what I want to highlight to you is another strategy called elastography, which is pictured here in the image, which is a way to measure mechanical shear wave velocity or sound waves that can be estimated to be how proportional they are to scar tissue. And this is a reasonable alternative biopsy if this is available to you in your community. Next slide, I think, is a real important clinical point. A lot of people historically thought about anatomic imaging like ultrasound, CT scans, MRIs, and those are insensitive for determining underlying scar tissue. If you see severe scar tissue on that, that likely correlates with pathology. And these are the tools that are most appropriate for hepatocellular carcinoma screening. However, these are not the right tools for trying to figure out how much a patient has in regards to scar tissue. Next slide. This is actually taken directly from the simplified hepatitis C treatment guidance from the WASLD and IDSA. And They specifically note that for cirrhosis assessment, liver biopsy is not required. Cutoffs are suggested that if you have a FIB4 greater than 3.25, an APRI score greater than 2, a platelet count less than 150,000, or a FibroScan or a transelastography marker greater than 12.5, you should presume that advanced fibrosis is present as you make a plan. You should presume that cirrhosis is present. But if all your values are less than that, likelihood is that patient is unlikely to have cirrhosis. Now, there's always caveats in medicine. It's also important to make sure that the perfect doesn't become the enemy of the good when we try to facilitate access to resources and best care and treatment for people. If we move to the next slide, I will just want to highlight some other things I do during the initial evaluation. I try to assess the patient's understanding or client's understanding, explain the impact on the health and prognosis of hepatitis C infection, and introduce them to the idea of treatment. Immunizations for things like COVID-19, hepatitis A, hepatitis B, influenza, as well as pneumococcus, specifically if a patient has cirrhosis, are all critical interventions that we can do to reduce harm. And other interventions like counseling about abstinence from alcohol and appropriate use of acetaminophen, as well as NSAID use, are really important elements. Counseling or reviews transmission are things I give all my clients or patients during their first visit, telling them to keep their wounds covered, to clean up blood or body fluid spills with alcohol and or bleach, to avoid shared personal devices like razors, toothbrushes, or nail clippers, to use barrier protection for intimate contact. Although I will counsel my patients about the relative risk of hepatitis C transmission, the relative risk of hepatitis C being transmitted between a male and a female partner with insertive penile vaginal sex or with oral sex is about 1 in every 170 to 190,000 sex acts if sex is unprotected. With receptive anal sex, regardless of the gender of the partners, the risk is somewhere between 1 in 100 and 1 in 1,000. So order of magnitude different between those. So I do think that hepatitis C absolutely can be transmitted sexually, but it often depends on context. It also depends if other sexually transmitted infections are present and if there's trauma or bleeding at the time of sexual activity. The last bit, this is a bit much bigger talk, but if a patient is injecting drugs, I think ultimately we want to care for that person the best we can. We also want to inform and counsel that patient the best we can about resources that are available to them for safer approaches to injection drug use if they are not willing to abstain. The last slide or two that I have here is just highlighting resources that are available to you. The simplified hepatitis C guidance is available at www.hcvguidelines.org. Also, a simplified hepatitis C treatment eligibility algorithm that's used by the health department is also available at Tennessee.gov. And I have those websites at the top, and Mia's very helpfully sharing those in the chat box below. So these are great summaries that include the baseline evaluation, which really in a much prettier format and a much more digestible format and printable format includes all the information that I included, particularly about labs or imaging. And with that, we'll move on to the next slide, which I believe is a kind of a placeholder for me to see if anybody has any questions or follow-ups.
Dr. Chastain, I have a question. So my understanding is that TB, specifically TB medications, can be hard on the liver. Where does TB come into play with any of this?
Yeah, so I think it's a very interesting question and comment as far as the medications, and we recognize that there are two different aspects to tuberculosis management. There are medications that are metabolized by the liver and also medications that impact liver metabolism of other medications, specifically rifampin. And there's also other medications that are part of tuberculosis treatment regimens where hepatotoxicity can be present, things like isoniazid, pyrazinamide, as well as ethambutol to a lower degree. What I would say is that if I have a patient with tuberculosis as well as hepatitis C, when I had these discussions with our TB state director and other groups, a lot of this is about prioritizing which disease state is the most impactful. And often that means prioritizing tuberculosis, both from a public health and from an individual patient's health. However, once you get beyond the initial start of TB therapy, it's a great opportunity to engage someone in hepatitis C evaluation and care and treatment because they are also still plugged into that care environment. And we often can negotiate those drug-drug interactions subsequently. The initial 2 months of treatment for tuberculosis with standard regimens are the time period that I would avoid adding too much complexity. But it's also important to highlight that treating hepatitis C sometimes is necessary to actually avoid some of that severe hepatotoxicity or those liver inflammation issues. So sometimes in unique scenarios, we'll navigate that. So a lot of this comes down to very close monitoring and in concert prioritizing tuberculosis treatment along with hepatitis C management. The other piece is how to balance a rifamycin as part of the regimen, which many people might recognize as rifampin, rifabutin, or rifapentine. And those medications can often dramatically impact the metabolism of hepatitis C therapy. And so if hepatitis C therapy is thought to be necessary and part of the timeline during tuberculosis treatment, we often will need to pivot to a rifamycin-free tuberculosis regimen, which is possible and is plausible, but again, can have pretty big impacts on the length and duration of different therapies. And so generally speaking, we often prioritize tuberculosis therapies, monitor for liver dysfunction closely, and try to engage a patient care. Upon occasion, we will concomitantly treat, but we'll have to watch out for drug-drug interactions as well. A very appropriate question, especially when people are working in a variety of health department settings.
Thank you. I have one more question, but before that, Dr. Allen, do you have anything you want to add to that?
No other things, but yeah, we definitely want to assess the liver function before we determined if we were going to treat both at the same time. That would be my main input, is wanting to establish what Dr. Chastain had already emphasized.
So my other question is, Dr. Chastain, you mentioned, screening for pregnancy. And so if someone is determined to be pregnant, how do you counsel them? What do you say?
I think this is a evolving area because if you go to the guidelines actually now state, as opposed to that hepatitis C treatment is not recommended because there's no therapies that have been approved in the context of pregnancy. Now the guidelines emphasize that the decision to treat hepatitis C during pregnancy should be made in concert with the patient, discussing the risks and benefits as well as uncertainties related to therapy. What we know at this point is that there are case series and case reports of women being treated for hepatitis C and being treated effectively during pregnancy with no evident negative outcomes related to either the pregnancy or to the infant. We also recognize, and I can recognize this anecdotally, this occurs, I think, with anybody who does high volumes of hepatitis C treatment, where incidentally, you might have counseled individuals, but individuals may still become pregnant during context of therapy, and you have to negotiate that. There are ongoing clinical trials that actually are looking at this question as well. If I have an individual who's pregnant, who's referred to me who's hepatitis C, I will discuss what we know about vertical transmission of mother to child. I will discuss with them what is known and not known about hepatitis C treatment in that context. And then we will try to come to a shared decision regarding the benefits and risks and the optimal plan for that individual. I would say in the past that has most consistently leaned towards waiting till post-pregnancy to treat that individual. I think that we are increasingly, with more and more data, moving towards more individuals choosing to either initiate treatment or to take treatment during pregnancy. And I think as we get more data, there'll be more movement in that regard. How much initial baseline evaluation I perform is contingent on those decisions. Because if someone is currently pregnant, there can be a variety of laboratory studies that may be impacted by the pregnancy, and also staging data that we can acquire during pregnancy might be impacted just by the fact that there might be a fetus between the FibroScan and the target organ. So those types of things I might defer if we're not going to pursue. On the flip side, if we are going to pursue treatment, then I have to contextualize that these laboratory studies or these other pieces of staging data may not be validated in pregnant populations. Generally speaking, people who are pregnant are younger than the full spectrum that we care for in people with hepatitis C, and thus that often means that patients who are pregnant have a lower likelihood of advanced liver fibrosis, just considering the demographics of the groups.
Thank you. And I believe you spoke about that last time too, but I'm going to ask every time because I think it's just a really important point to discuss. Laura, did you have a question?
Just really quickly. So Dr. Chastain, is there a preferred trimester in which to treat these women?
Laura, it's a great question. And then I see a couple of things that come across the chat. We don't have a lot of data. I think just generally speaking and based on experience with other conditions, whether it be with HIV, whether it be with hepatitis B and others, is that treating a woman later in pregnancy avoids the concern about teratogenic effects on a fetus. The flip side of that is that we also recognize that maintaining the health of someone who's pregnant is really paramount to a fetus's development and also for infant health. And so there's this balance also about trying to implement earlier treatments. We also, if we're trying to prevent vertical transmission at the time of birth, you want to have completed treatment, if at all possible, to reduce the likelihood of that virus. So it's this, a lot of the clinical trials are looking at this as often enrolling women in their second trimester with goals of completing therapy prior to the time of delivery. Two things I see in the chat box. I see a note from Jennifer Bird. Is it possible for us to get something in writing or direct where to find statistics data about rates of sexual transmission during sexual contact, number of experiences, route, et cetera? Jennifer, it's a great question. I will try to pull the article that was led by Nora Terrell out of the group at University of California, San Francisco, about this data and try to share it back to you. There might be some additional education framed or infographic data related to that. But we can try to pull a primary source and share as well as look for other resources, which is great. The second thing I see in the chat box from Jonathan Johnson, if they do decide to receive treatment during pregnancy, would you say that's something their PCP should manage or should that be referred to ID? I think it's a great question, Jonathan. I think ultimately, from my perspective, and I certainly would welcome the group's input, I personally don't have a lot of experience of treating people during pregnancy. And so thus, I would say it's really hard for me to put that conversation onto another individual. That being said, I also don't want to remove the opportunity for treatment for an individual if it's feasible or attainable. This is definitely one of those places that, while I certainly would say it's very open as a specialist, I would be happy to see these type of people. I also recognize not all people can reach me or someone like me. And so using this as a type of place to bounce ideas off, to discuss a case, to identify what counseling could be provided would be great. And also offline connections as far as specific TA can also be helpful.
Thank you so much. Any other questions for Dr. Chastain? And also, if you think of any between now and the next session, we can take them then too.